this is a great cartoon because our evolution of what we know about lipid disorders, what we know about inflammatory markers, what we know about advanced lipid labs and genetic testing is evolving on a regular basis. I think I pointed out last evening, when I started running a lipid clinic, triglycerides of 300 were normal. Then they were 200 with the ATP1. With the ATP3, they were 150. Now, a joint statement from the AHA and the ACC are saying triglycerides should be less, a normal triglyceride is less than 100. And these things become more and more important because most physicians are going to use a lipid profile to identify risk of premature heart disease in their population, their patient population. And I can guarantee you that almost none of your physicians realize that it is only sensitive in identifying 40 to 50% of that risk. At least half of the patients that have a premature vascular event will have a normal traditional lipid profile. When you add the advanced lipid parameters and some of the genetic testing and the inflammatory marker testing, you can go from about a 50% identification rate to over 90%. You really fulfill, I think, what the purpose of these tests is to identify people at risk. The earlier you can do that, the earlier you can intervene, and the better the outcomes are. And that was published in a paper just last week in the American Journal of Cardiology. So again, this kind of graphically conveys that point that, this is what we do with the traditional lipid profile, and this is all the extra potential information we have that your doctors can get by doing an advanced lab like the Hunter Heart Profile. This is a traditional profile of a 51-year-old guy with a metabolic syndrome, and these numbers are, for the most part, great. I mean, they're almost too good for this guy to be metabolic syndrome. His triglycerides are normal, which is very unusual. His total HDL is normal, which is unusual for metabolic syndrome. But I can guarantee you that if this guy walked into any physician's office, certainly in Central Florida, he would be told he's fine and come back for your physical next year. Well, when you do the advanced risk markers, he goes from looking great to looking terrible. This is an enzyme. We use acronyms in medicine for a very good reason. That's lipoprotein-associated phospholipase A2. And I'll be calling it plaque from now on. But it's an enzyme that is a direct marker for the burden of unstable plaque. It's an inflammatory marker, but unlike almost any other inflammatory marker, it is specific for inflammation in the vascular bed. If you have a toothache, if you had arthritis, if you're getting over a cold, your hsCRP may be high, but your plaque is going to be normal unless you've got atherosclerosis going on. It's actually made by some of the cells that are intimately involved in the atherosclerotic process. This guy's LP little a is very high as well. And we'll talk about that in a minute when we look at each individual one, but the cholesterol content of LP little a is 10 times as atherogenic as the cholesterol content of LDL cholesterol. And it's a very, very important player, especially in certain ethnic groups, so we can talk about if you're interested. But so I'll start with the two inflammatory markers that are provided by the Hunter lab. And one is the plaque test. And if this is over 200, it means they have active disease. They have an area of unstable plaque that's being developed now because it only comes from plaque that is actively undergoing transformation. It is FDA cleared for both predicting risk of stroke and cardiovascular disease, heart disease. And hsCRP, high sensitivity C-reactive protein, is a non-specific inflammatory marker. People get a little confused. C-reactive protein has been around as a marker in rheumatologic disorders since the 1930s. HS, high sensitivity, is just the fact that it's the same molecule that's being measured, but it's being measured which is inside what used to be considered the normal range. It's very sensitive for determination. But again, it's not specific for vascular inflammation. It got its main claim to fame and a lot of interest in the medical literature and the public literature with the Jupiter trial. That was this big study that AstraZeneca did with Crestor, and they took people who would not qualify for lipid-lowering therapy, and they took 13,000 to 18,000 of these people. They had normal lipid profiles. They fell within the guidelines for the National Cholesterol Education Program for not requiring drug treatment, but they all had an elevated C-reactive protein. That study was supposed to go on for 5 years, but was terminated at the end of 18 months when the ethics committee said, look, it's unethical not to put everybody on the statin, because they reduced events by 44% in a group that wouldn't have gotten drug treatment in the first place. And what's particularly powerful is if both the plaque and the C-reactive protein are elevated, your risk for stroke goes up 11 times. And that gives you your doctors a tremendous opportunity to intervene before something bad really happens. And the things that you can do a similar slide for HSCRP. This is for plaque. But the things that we normally do to treat atherosclerosis, to lower the LDL, to lower the triglycerides, to lower Lp(a), when they work, they're all associated with a drop in the inflammatory markers. But what do you follow, the LDL or the inflammatory markers? And I can tell you, in the plaque trial, in a post hoc analysis done by Paul Ridker about a year ago, he looked at the benefits. He broke the groups down into the group on drug treatment that lowered the LDL, but the HSCRP didn't change. And that reduced the risk of an event by about 50%. He looked at the group that the LDL didn't change very much, but the C-reactive protein dropped. That group reduced events by about 40%. If you look at the group where both the LDL and the inflammatory marker dropped, they had an 80% event reduction rate. So, I mean, the clinical take-home point I usually give when I talk to physicians or healthcare providers is you want to get the LDL to goal according to the National Cholesterol Education Program, but if those inflammatory markers don't drop, you're not done yet. You've still got a lot of residual risk and an opportunity to reduce that risk. 2 years ago, there was a major consensus meeting on inflammatory markers, specifically on plaque. And it was chaired by Mike Davidson in Chicago, a panel of world experts. And they basically said that if your plaque is elevated and you're at your LDL goal, you should target your LDL 30 points below that. So if the ATP says your LDL goal is 100, but your plaque is elevated, your new goal is now 70. And I would actually take that one step further. After I get him to 70 for 2 or 3 months, I would recheck the plaque, and if it's still elevated, I get him even lower than that. You know, atherosclerosis, coronary heart disease, has undergone this evolution over the last 20, 30 years, where and in the beginning it started out as a plumbing disorder, where your pipes got clogged up and blood didn't get to where it was supposed to go. And then it became what we referred to as a response to injury, and that slowly evolved into this inflammatory disease. And atherosclerosis is a classic inflammatory disease. You get a toxin in a tissue space, which in this case is oxidized LDL, Lp(a), whatever, that induces an inflammatory response by the endothelial cells that recruit white blood cells that ultimately become the foam cells. I'll show you that in a little bit. And again, the greater the risk, the more vulnerable plaque there is, the more the inflammatory markers are going to be elevated, and the better chance your doctors have of stratifying the risk, identifying it, and then treating it aggressively. And this is all endorsed by the ATP3, the American College of Cardiology, the American Heart Association. And again, this kind of just looks a little bit at the spectrum from normal to this gradual thickening. And at this early stage is where the HSCRP will be elevated by itself. As the plaque burden gets larger, and now I'm getting confused myself because I'm not talking about PLAC, I'm talking about the atherosclerotic plaque. As this area gets bigger, the plaque starts being produced because this is where it comes from. And then there's some work on some newer inflammatory markers that are even later on in the process, like metalloproteases and stuff. But really, you want to do the intervention here before the plaque ruptures and causes a heart attack or a stroke or whatever. Some of the advanced lipid markers that we use, I've been using these literally for 15 years, is lipoprotein Lp(a), which is a very small, dense LDL-like particle made in the liver that's attached to apo(a), a very unique apolipoprotein. And again, it's kind of a double whammy for heart disease because it causes classic atherosclerosis just like LDL cholesterol does. But it also actually induces a prothrombotic state, so the patient's much more likely to clot as well. And again, 10 times as predictive than LDL cholesterol. Usually, diet, exercise have no effect. The only two dietary influences that will affect Lp(a) levels are a restriction in trans fats. That's one of the reasons why we think trans fats are so absolutely terribly bad and accelerate disease so fast, is because it's the only dietary intervention that will raise Lp(a). And the other one, which is my favorite, is alcohol lowers Lp(a). Statins don't affect Lp(a) levels at all, unless. Well, actually, let me say the best a statin can do is not affect Lp(a) levels at all. Some of the statins actually raise Lp(a), like Lipitor, Mevacor, and Baycol used to, by as much as 30%. The mainstay for therapy of Lp(a) is niacin, fish oils, the omega-3 fatty acids, fenofibrate, aspirin. One of the ways we think aspirin is cardioprotective is it actually lowers Lp(a). LDL is not one thing, and hopefully everybody in this room realizes that. LDL is present in the circulation in a very broad spectrum of particle size and density. And I always like to emphasize that there is no such thing as good LDL. All LDL is bad, but the small, dense LDL is by far the worst. We've got 5 or 6 epidemiologic trials, a couple of them are prospective now, to show that you can get 2 guys in your doctor's exam rooms with LDLs of 140. One guy's got mainly small dense LDL, the pattern B, if you will, and the other guy's got the large fluffy LDL. The guy with the small dense has got 3 times the risk of a premature heart attack than the guy with the large fluffy, even though their numbers are exactly the same. This has got there's a lot of opportunity to change this. Diet can affect that. There's a spectrum of drugs that can shift LDL particle size. Lifestyle intervention will shift LDL particle size. ApoB is, in the United States, and literally almost only in the United States, our lipid modifying scheme, the National Cholesterol Education Program, is focused on LDL. And then in the last version, they added non-HDL as a secondary target. In the rest of the world, literally, the target and all the treatment recommendations are based on ApoB. There is one ApoB in every lipid particle that can cause atherosclerosis. It includes LDL, but it also includes, there's an ApoB on Lp(a), there's an ApoB on IDL, an ApoB on VLDL, that are all potential causes of atherosclerosis. And in every epidemiologic study that I've seen done in the last 10 or 15 years, ApoB is a better predictor of cardiovascular risk than LDL. There's not one study that even suggests LDL is better than ApoB. HDL, just like LDL is not one thing, HDL is present in a spectrum. It's been artificially divided into 2 main categories and then subdivided again into about 5 categories. But we make HDL, this nascent HDL, pre-beta HDL, in the liver and the small intestine. It's like a little flat hockey puck. It goes around the circulation, and the ApoA1 on HDL interacts with a transporter on peripheral tissue like the foam cells, and it sucks the cholesterol out of the cell. And that little hockey puck turns into like a football, and that's HDL3. And then it becomes a spherical particle, that's HDL2. And when we normally say that HDL is cardioprotective, if you really know what's going on, what you mean is HDL2 is cardioprotective. HDL3, while it's not bad for you, really offers no protection at all. It's basically felt that this is a marker for reverse transport. If your reverse transport is working properly, then you should have mainly HDL2, the big fluffy spherical HDL. If you've got a lot of HDL3 running around, there's probably something wrong with your reverse transport. There's a mutation in the ApoA1, there's a mutation in the ABCA1 transporter, there's something wrong with your lipoprotein lipase enzymes. But again, it's an identification of risk. You get the guy with a normal lipid profile, but he still has a 50% chance of going on to develop a cardiovascular event. What drives most of that residual risk in men is the HDL2. They've got an HDL of 45 or 50, which looks great, but their HDL2 is 5. And what drives residual risk in women is the LP little a. When you do a regular lipid panel, you get the LDL number, more likely calculated anyway, but that LDL is really the LDL, the IDL, and the LP little a all added together. And again, in women, there are a lot of women out there who have an LDL of 100, but their LP little a is 50. So again, when you look at traditional lipid profile, they look fine, but when you look at the advanced profiles, they're starting to get a lot of residual risk. Vitamin D has undergone an explosion in the lab business in the last 5-6 years, I guess. The deficiency the rates of deficiency are very high. I think this number dramatically underestimates it. It's about 40% in Florida. I mean, you think with the sunshine it would be, but the dermatologist has been very good at getting people to put on sunscreen and wear hats, and it's important because vitamin D, I didn't realize this until I did a symposium about 2 or 3 years ago, but there is a vitamin D receptor on every cell type in the human body. And for decades, we thought all vitamin D was regulate bone metabolism, and you needed it for strong, healthy bones. Well, now we know that you need vitamin D for proper muscle function, you need it for proper nerve function, you need it for cardiovascular functioning, and if your vitamin Ds are low, your risk of heart attack is increased by about a factor of 2. I run a referral practice. If somebody can get their LDL to go with Crestor 20, I don't get to see them. But my biggest referral are people who've had a heart attack, their lipid profile is off the wall, and they can't take any statin because of muscle pain. And that occurs in about 20% of the American population. They get muscle pain and joint pain on statins so severe that they stop taking them or refuse to take them. Those patients are almost always vitamin D deficient. And when you replace the vitamin D, the 25-hydroxy vitamin D, and get that level over 30, 95% of those people who couldn't take a statin before can now take a statin. Very clinically useful. There are also some interesting genetic testing that's being developed now, and one that we've had around for a while is the ApoE genotype. There are 3 alleles for ApoE, ApoE2, 3, and 4, and they carry a bunch of interesting implications. E4 is a marker, number 1, for hyperabsorbers of cholesterol. These are people, and everybody's cholesterol level is determined by some balance of absorption and production. Some you get from your diet, some your body just makes. And there are people at both ends of the spectrum where some people, almost all their cholesterol is a result of the diet, they're hyperabsorbers, and there are other people who are hyperproducers. They can eat wood chips and cardboard and their LDL is still 190. If you carry the E4 allele, you're a hyperabsorber. These people do much better with diet. These are the people that my dietitian spends a lot more time with. And these are people who do much better with cholesterol absorption inhibitors like Zetia or Welchol than they do with statins. It's also interesting because it increases the risk of cardiovascular disease by about 1.5 to 2 times, especially in women. It actually identifies a marker for potential early Alzheimer's disease. We're actually getting neurologists sending us patients now who have a family history of premature Alzheimer's to get the ApoE genotypes. If you're E4, you have a 34 times increase in risk of getting premature Alzheimer's. It will come on at an earlier age than regular Alzheimer's, and it will be much more severe in a rapid deteriorating course. And again, E2s are the ones that are hyperproducers, and they do much better with drugs like statins and niacin and fibrates. Factor V Leiden, that's not something I use a lot, but just because it doesn't really fit into a lipid clinic per se, but this is a mutation that can be identified that increases the risk of deep vein thrombosis and pulmonary emboli dramatically. And it's oftentimes nice to know if they've got that, because these are the people who say they're flying from Florida to California and sitting in the chair for 6 hours. They may want to take a Coumadin or one of the short molecular weight heparin injections prior to that. And then there's a bunch of metabolic studies that Hunter provides that are very useful, if not essential, when you're evaluating an initial patient, and most of the time useful when you follow up your response to therapy and look for toxicities and stuff. You know, thyroid disorders, TSH. I said last night, I probably diagnosed hypothyroidism in someone who didn't know they had it at least 2 or 3 times a month. And again, it's very important because these people don't need a statin. They need Synthroid. And almost invariably, when you correct the thyroid abnormality, their lipid disorder goes away. If you're hypothyroid, your LP-little level will go up, your LDL will stay about the same, but it will get small and dense, your HDL will go down, and your triglycerides will go up. And those lipid abnormalities are very unresponsive to traditional drug treatments unless you correct the thyroid disorder. Alk Phos is important for the initial evaluation because you're looking for what are called cholestatic disorders, or certain liver disorders that are associated with a very unique kind of dyslipidemia where statin therapy is absolutely contraindicated, and a bunch of other, and that can basically, at least the start for that evaluation can be identified with an elevated Alk Phos. These are some other inflammatory markers. Creatinine and renal function have to be monitored when you're going on a fibrate like fenofibrate, Tricor, Trilipics. The Hunter Hart reports can actually help identify metabolic syndrome, which is kind of nice on a lab paper, but we joked last night, you don't really need to do that. These are the people whose belt buckle points to the floor. You know, you can pick them out of the waiting room from a mile away. It's not, they're not hard to find. One unique part with Hunter Hart, and I've worked with, at some point or other, I think almost every lab company, that advanced lipid lab company that exists, is they make it easy for the doctors. The biggest barrier for getting someone to use this test is they don't want to order something they don't know what to do with. And this gives a simplified report and a customized treatment guide. There's a summary of what the results show, the low LDL. It breaks it down into priorities. Your first priority is always going to be to lower LDL, and based on what the other things are, will tell you what you can use to lower the LDL. You know, if LP level is high, you probably want to avoid atorvastatin. And if LP-A is high, you can consider hypothyroidism, rule that out. The other things that you do, but this way, you know, the doctor is going to have some kind of guidance in terms of what to do with those results. To summarize, especially when you're talking with your doctors, I mean, you certainly are much more sensitive at identifying risk. You double your ability to identify patients at risk with the Hunter compared to a regular lipid profile. Not only do you know that the risk is higher, you know where that risk is coming from, and you generate, and this is important, literally a personalized treatment plan, recommendation anyway. The report is easy to look at. The patients love the green, the yellow, and the red. I mean, it's very intuitive as to what is bad on their report when they need to do that. And again, if there's any questions or anything you've gotten feedback from your doctors or questions that you weren't able to answer, I'll be glad to see if I can.
Paul, I stepped out of the room. I don't know if you covered it, but last night when you and Mike and I were sitting together before the dinner, I asked you about, well, what should you do with pediatrics with kids? How soon should you actually run with these advanced kids?
Yeah, it's interesting. It's not being done, but the National Cholesterol Education Program had a joint meeting with the American Academy of Pediatrics, and there's a treatment guideline that's about 80 pages. But basically, the final summary is that if the child has got a family history of premature heart disease or a family history and a first-degree relative of dyslipidemia, they literally should be screened when they're 2 years old. Now, those of you who know the answer don't say, but what percentage of American kids qualify on those two criteria? 70%. You might as well screen every kid. And a lot of that early screening is based on finding genetic disorders early so that you can intervene before, you know, the guy gets his heart attack at 25 because his LDL is really 400 and he's a familial hyperlipidemic, or they've got an LP-A level that's 75. You know, LP-A levels don't change with age. The LP-A you've got now, assuming you don't acquire one of the secondary causes, is the same that you had when you were 6 months old. So again, it can identify risks in that population, but yeah, it's very useful in pediatric age groups. This is really good for rheumatology clinics because in a rheumatology clinic, an HSCRP is totally worthless.
Okay. So the
HSCRP is always going to be, if they're, by virtue of them seeing somebody in a rheumatology clinic, they've got an autoimmune or inflammatory disorder, and it's going to be elevated. So it eliminates that possibility that they've got underlying atherosclerosis because the background noise is so big from the other causes of inflammation. But the plaque in that test is going to be very useful because that's not increased in rheumatologic disorders. Specifically to the vasculature, yes.
More basic question, but we understand that you're recommending this be done instead of routine lipids. Yeah.
Absolutely.
Okay. And up to 4 times a year in place of a regular lipid, or?
Well, it depends on what you're following and what you're treating and what the LDL levels and stuff are. But yeah, in my vision of a perfect lipid world, the traditional lipid profile will not exist in another 5 years. There'll only be the advanced lipid labs like the Hunter Heart. Because, again, the purpose of these labs is to identify risk and then to monitor therapy. Well, you're only identifying half the risk, so you might as well flip a coin. You're better off than running a lab, and it's a lot cheaper. And you really can't monitor therapy because you're missing half the causes of residual risk. So you don't know if your drug is making it better or worse. So, yeah, I mean, as often as your doctors now are doing a regular lipid panel, they should be doing an advanced lab like Hunter Heart. Sometimes that's once a year. Sometimes it's once every 5 years in a young age group. But it very well may be 4 times a year if they're high risk on multiple therapies. Yeah, one of the things the expanded labs do, I noticed when I started using them outside of a research context about 10 or 15 years ago regularly, my use of combination therapy went through the roof. It went from about 10% to now it's at least 60-70% of my people are on combination therapies now.
Yeah, well, last night you talked a little bit, I think, before your talk. I thought it was very interesting because a lot of the traditionalists are using the niacin compounds, and that's the last thing that the patient wants to do is take their next dose. Could you kind of discuss how the lipid guys have to manage something like that?
Niacin is a very challenging drug to work with. Mainly because of the side effect profile. And by that, I mean, niacin does a lot of things that are relatively bad. It can induce insulin insensitivity or resistance. So in people who are diabetic or very nearly diabetic, we try to avoid the niacin. The main problem, though, is the flushing. I mean, I'm not talking about you just feel a little glow. You're burning up. And I've actually had people go to the emergency room thinking they were having a stroke or they're having anaphylactic reactions from their meds. And that was niacin. It also increases gastric acidity. It's got much higher liver toxicity than statins do, but everybody worries about their liver with statins and nobody with over-the-counter niacin. But niacin does everything right, almost everything right, but it's very difficult to take. And there are tricks when you have to use niacin. I use Niaspan, the branded product, or slow niacin, the only unbranded product. Actually, the brand name is SLO niacin. They take an aspirin, a non-enteric-coated, regular Norwich aspirin 1 hour before. They take their niacin at bedtime with a high-fiber snack like a granola bar or a bran muffin, and then they go to bed and you hope they flush while they're sleeping. And once you've been on the drug for any length of time, you quickly develop tachyphylaxis to that. You don't flush every time. You flush every time you increase the dose or if you miss a dose. But once you're able to stay on it for about 2 weeks, you'll do pretty well. It's just that first 2-week challenge. And we talked, there's some drugs in development now. Merck has got a specific blocker for the flushing response, which we know where it comes from now. It's a prostaglandin-mediated thing, so that's probably about 1.5 years away from FDA approval. But
You talked last night about how quickly you can lower some of these risk markers. Could you, unless you discussed it earlier?
No. If you look at traditional lipid risk factors, LDL number total, LDL particle size, triglycerides, LP(a) will drop within 6 weeks at the most of whatever therapy you initiate. HDL raising, and specifically HDL2 subfraction, can take up to 6 months. Inflammatory markers, I usually bring them back within about 6 to 8 weeks to recheck the inflammatory markers. Most of the studies that show the drugs affecting it were done in the 6 to 8 week time frame. But yeah, you can monitor your response to therapy fairly quickly, with the exception of raising HDL. That just takes longer.
Is it accurate to say you can dramatically lower your risk in a matter of 3 to 6 months?
Yeah. There's some very, I mean, yeah, you absolutely can, or you can increase your risk in a very short period of time. There are a couple of, I'm serious, there's a very fascinating epidemiologic study that was done in New Zealand, and this is now 10 years old, but I used to use it all the time when I spoke for Merck, because New Zealand has a national health insurance plan, and basically everybody in the health system is in the computer. And they had everybody with known heart disease, and they were all on Zocor at the time, and for like 2.5 years, every 6 months, there'd be like 2 events, 2 events, 3 events, 2 events in that population, recurrent events. Then the national health system switched from Zocor to Lescol. And there's a reason why they call it Lescol, because it doesn't lower LDL. Their LDLs went up by about 20 points. In the 6-month period following the shift, it was 2, 2, 3, 2, 9. In just 6 months.